Well, there's one thing I will certainly agree with Oliver on, and that this is all about consent. It's all about properly informing your patient and allowing them to make an informed choice. Have I got... So just look at the title here. I think this is a debate, okay? And the debate depends on the exact terminology. Spinal anesthesia should be the default technique for ASA1 patients undergoing day-case knee arthroscopy. Day-case knee arthroscopy. Okay, thank you. My screen isn't coming up here. I don't know why. Oh, it's down there. Right, okay. Why is it not working? I need to progress through. Do I have to press the button on this thing?
Yes, use that one.
All right, okay. Right, okay. So you all know me. I'm from Chester. I'm a consultant anaesthetist there, and I've actually been associated with RAUK and ESRA for a very long time. And I'm actually a past president of this august society. So it's really slightly embarrassing that I'm up here arguing against a regional anaesthetic technique. However, I am very keen on regional anaesthesia, and I'm very keen on regional anaesthesia doesn't get a bad name, that we use it responsibly and appropriately and when indicated. And my view is that I wouldn't have a spinal anaesthetic for a day-case knee arthroscopy, and therefore I would expect that a properly informed patient wouldn't either. I nevertheless feel that spinal anaesthesia for day-case surgery is a very valuable technique. Newer agents, particularly prilocaine and chloroprocaine, on which I'll be concentrating most of my talk, as these are the ideal drugs for if you are going to do a day-case spinal anaesthetic, they have gracefully extended the indications. In high ASA patients can now be done on the day-case basis, and anywhere from procedures below the limb, where you may have been rather unhappy to administer a general anaesthetic in the past. We have patients who are a high-risk general anaesthetic who we would be perfectly happy doing a spinal anaesthetic on in the day-case environment. And there are, of course, those patients who actually want to watch their surgery. I disagree with Ollie that there are lots of patients who want to watch their own surgery. Most of my patients in Chester, when they approach me, are completely the opposite. They don't want to watch their surgery at all. And in my regional anaesthesia practice, it usually takes me, it's quite an effort to actually convince patients of the benefits of awake surgery in upper limb surgery, for example. And therefore, in my view, it is not the default technique for day surgery in ASA1 patients. Now, you need to think in your own mind what default means. And I propose that default actually means that it's the main option that you present to the patient in the first place. I'm aware that in some particularly European institutions, it may be the only option presented to patients. And default actually means that it is the option you choose unless someone or something changes it. I think on that word alone, I would argue to vote against this motion. If you don't agree with anything else I've said, there is no such thing as a default technique for any anaesthetic procedure. You have to sit down with the patient and you have a GMC responsibility to give them the risks and benefits of a proposed technique and its alternatives. And I would remind you to examine your consciences in that respect. What's the alternative to a spinal? Well, it's a 22-gauge cannula, a little blue one, okay? It's fentanyl, 50 micrograms in my case, when I do it, propofol induction, shove in an LMA, nitrous oxide, oxygen, sevoflurane, gives them a bit of Dex, some intravenous NSAID, IV paracetamol, 20 mils of bupivacaine by the surgeon. We're changing that to 0.2% ropivacaine soon because of minor concerns about chondrotoxicity. And these are my last 20 patients. I've recorded these in preparation for this talk, and I thought you might be interested in some of my anecdotes. So 20 of these patients, induction to theatre entry, a mean of 3.6 minutes, range 3 to 8 minutes. I am very quick. Recovery time, mean of 15 minutes, range of 11 to 27. Recovery VRS, on a VRS score of 0 to 3, median 0, range 0 to 2. One patient had IV tramadol 50 milligrams in recovery. Recovery post-operative nausea and vomiting, no vomiting. One patient was nauseated and required ondansetron. Recovery discharge time, mean of 2.8 hours out of hospital, range 1.2 to 3.6. No adverse events. On the ward, before discharge, no vomiting, no treatment for nausea. 8 patients had cocodamol, ibuprofen, or both. Now, I could rest my case. This is a straightforward technique. This is for an ASA1 patient. It's straightforward, it's quick, it's easy, it's complication, well, on an anecdote of 20 cases, not necessarily complication-free, but it's certainly straightforward. So let's move on to some of the minor issues in GAs and spinals. So first of all, when you're talking to your patient, these are the sort of things I think you need to tell them. Well, you're going to have one needle for your GA, and you're going to have 3 needles, and one of them is quite big for your spinal anesthetic. Okay, the third needle, if you do your second needle right, you shouldn't feel it. But actually, in my practice, some patients still feel some discomfort, even after local anesthetic infiltration. You have to tell the patient that with a general anesthetic, obviously they're going to be, that your intention is they're going to be asleep, and that in a spinal anesthetic they're going to be awake, and they can watch their surgery if they wish. Now that depends, that is an advantage or a disadvantage depending on the patient's attitude, okay? There are some patients who actually find that really exciting that they can watch their surgery, and there are some surgeons who find it really great that they can show off in front of the patient, okay? But in my experience, most patients are actually the opposite. They don't want to see the surgery. There's a 3 to 10 minute induction for general anesthesia, and there's a 10 to 15 minute induction for spinal anesthesia. I'll go into more detail in a minute. 15 minutes or so for recovery, and you can bypass recovery with the new agents with spinal anesthesia, maybe 5 minutes, one set of observations in other units. Now let's look at some data on that. This is a meta-analysis of regional anesthesia versus general anesthesia by Liu, published in 2005. There were 15 papers on spinal anesthesia, 7 of which were for knee arthroscopy. These all used low-dose bupivacaine techniques, but there was no attempt to control for antiemesis or multimodal analgesia, and that's important for you to recognize. Looking at this, I've highlighted the induction time with bupivacaine, low-dose bupivacaine. Induction time is 17.8 minutes for spinal anesthesia and 7.8 for general anesthesia, which mirrors my practice. In other words, it takes about 10 minutes more to put a spinal anesthetic in than do a general anesthetic. But, you know, maybe that might, I don't see how that would change with any newer agents, but, you know, let's look at the latest stuff on chloroprocaine, which is the drug of the moment. Trying to find a comparison between these new low-dose agents and general anesthesia was very difficult. This is the only study I could find. This is a poor study done by Campanova. It's a retrospective chart review of 61 patients, half of whom had general anesthesia and half of whom had a chloroprocaine spinal anesthetic. There was no attempt to control again for antiemesis or multimodal analgesia. They claim that the anesthesia time was comparable between the two groups. They also say that they managed to bypass the PACU in all their spinal patients. But if you actually look at into the results section, you find out that the surgical time was 8 minutes shorter in the spinal group, and the anesthetic time is actually defined as the total time the anaesthetist spent with the patient, i.e., the whole operative phase. So therefore, actually, the spinal anesthetic took 8 minutes longer. Okay. So it actually does take longer to do a spinal anesthetic than a general anesthetic. So discharge time. Well, I mean, we can skim over this because I agree with Oliver that with the newer agents there isn't any difference in discharge time. The patients can get out of hospital just as quick. This isn't about discharge time. Okay. So I'm going to move through that again. Here's the discharge time was predictably longer in Liu's series in bupivacaine. Notice 800 patients combined in that meta-analysis versus the 30 in the chloroprocaine group. But notice also that in the chloroprocaine group study, the discharge time was 326 minutes for the general anesthesia group. But 10 years earlier in the Liu study, it was only 150 minutes. So in some bizarre reason, they're spending 5 hours of discharging their general anesthesia patients, and they then do a cost analysis on that basis. It's completely ridiculous, sorry. Minor side effects are more common with a general anesthetic than with a spinal. Okay, things like postoperative nausea and vomiting and pain control. But as I said, all these studies have not controlled for those two factors. And it seems to me that if you were actually to give some prophylactic antiemetics and some prophylactic NSAIDs and paracetamol and a local anesthetic infiltration, I wouldn't expect there to be very much difference, particularly with a really short-acting agent like chloroprocaine. But there is some evidence that that is the case, and if you look at the bupivacaine study, the loose study here, you'll see that there is an increased incidence of nausea and vomiting and need for analgesia, but that this was 14% in the general anesthesia group. That doesn't reflect my practice. My post-op nausea and vomiting rate for ASA1 patients is about 8%, so there's not a big difference. And in the chloroprocaine study, yes, there was a difference, but on the extreme side, on the severe pain side, there was no difference. Retention, well, we could throw that out, and I agree that the evidence suggests now with the modern agents that there is a very minimal, well, if any, risk of urinary retention with the new agents. However, I'm an ASA1 patient, and I am 62, and I have early prostatic symptoms, and the thought of having a nasty tube shoved into my bladder is really rather disturbing. So I would want to minimize that risk at all counts. And finally, the Campanovo paper suggested that spinal anesthesia was cheaper, 25 Swiss francs cheaper, but this was based entirely on the staffing costs of bypassing the PACU and an unreasonably prolonged general anesthesia time of 5.4 hours. So I think that doesn't work out at all. I want to move on to failure because this is an important issue. Munhaus suggested there was a 1% failure rate. That's technical failure rate, not entering the thecal space. My practice is I actually have a 3% technical failure rate. That's 3 patients in 100. I give up and convert to general anesthesia. And that's because I don't like digging around. I will only go for move to one space, and I'll only have 2 or 3 needle redirections, because I believe that if I start digging around, the advantages of spinal anesthesia decrease rapidly as I increase the risk of neurological damage. There is, but I have to admit, in ASA1 patients, you're likely to be more successful than in the most of your practice, which will be in ASA3 old ladies having fractured neck of femur. More concerning, though, is that Munhal suggested there was a 4% GA conversion rate, and Levy was up at 17% GA conversion rate on an intention to treat basis. If you tell that to patients, you'd be a little upset. But maybe the new agents are better. Well, this is the Tunken's report from 2016. 6% of the chloroprocaine patients had to be converted to general anesthesia. This is the Tunken's paper. I don't know how you pronounce it. This is the results. 2 of 32 patients were converted to general anesthesia. Now, I think you need to, if that a rate of 6% certainly needs to be in the information base that you give the patients. Even more concerning is pain during surgery. Tunken's also reported that 13% of patients needed some form of strong analgesia during the surgery. All right? So pyritramide is an opiate with 0.75% potency of morphine, and sufentanil is a powerful short-acting opiate. That, again, is really rather concerning. But how often, to be fair, how often does general anesthesia fail? Well, Ollie mentioned that general anesthesia may keep you asleep. Well, true, but it only fails in the NAPS-5 study. The incidence of unintentional awareness is 1 in 8,000 if you intubate and ventilate them. Well, I'm not intubating and ventilating. They're all having a laryngeal mask, and the incidence of awareness from NAP if you don't intubate, give a paralysis, is about 1 in a million. So, and the other thing is about death. Ollie remarked on people dying as a result of having a general anesthesia, but these are ASA1 patients. The best data I could find was from the Australian New Zealand College of Anaesthetists, who with 9 million cases between 2009 and 2008 having general anesthesia. There were 2 ASA1 patients having dying as a result of general anesthesia, which is 1 in 4.5 million. So failure, GA conversion, difficult insertion, all cause delays, and in my view, they eliminate any financial advantage of increased theatre efficiency, even if these financial advantages exist. And then there's PDPH. Well, we know that the younger patients are at higher risk, whether they're male or female. We also know that females are at higher risk. And let's look at the data. Bratibo had a rate of 4% overall using 24 and 27 gauge needles and 1 blood patch. Despond in 98, 9.3% overall with 27 gauge needles and 1 blood patch. More recently, 2004, perhaps slightly better, 1.5% overall using 27 gauge needles. That's 3.7 in 1,000 or 1 in 270. Now, I use a 25 gauge Whittaker needle. I don't really like using anything smaller than that because of the feel. I feel I'll have a higher failure rate. I would have thought my incidence, as Ollie said, is around 1%. So patients need to be told that. There's an incidence of 1% of a nasty headache after a spinal anesthetic, and because of that nasty headache, you might have to have another needle put in and have a blood patch. That all needs to be in the information. Then there's TNS. Okay, TNS is rare, but with prilocaine, it's actually 0.8%. That's 1 in 122. 4 in 486 patients in a prospective study, in a review of prospective studies. And we also know that it's actually higher in knee arthroscopy specifically. 1 in 20 patients with chloroprocaine by Vagardi in 2012 had a cauda equina syndrome. Whether that's the same as TNS or not, I don't know, but it lasted 2 weeks, which is a bit unlikely to be TNS, which is usually resolved within a few days. Even with chloroprocaine, in a series of 4,000 patients, there were 5 cases. So it does happen, 1 in 800. I think a rate of 1 in 800, I wouldn't probably need to tell the patients about that. So that becomes, if you've got chloroprocaine, that becomes a non-issue. Nerve damage, right. Well, I found this very confusing and difficult in the literature because we've got to talk about, is it discomforting or drastically disabling? Is it temporary? Is it permanent? Is it peripheral? Is it central? And is there a difference between ASA1 patients and ASA3 patients? And the vast majority of the literature relates to high-risk patients, elderly patients, not ASA1 patients. So it's a confusing literature. But really what this comes down to is what is the incidence of permanent disabling nerve damage in an ASA1 patient having a day case general anesthetic compared to a spinal anesthetic? And NAP3 tells us some anecdote. In contrast to many of the other injuries considered in this project, nerve injury occurred most frequently in young, healthy patients and was equally frequently seen after spinal as epidural blockade. This is an anecdote from it, which I slightly unfairly describe. A young patient requested a spinal anesthetic for day case minor limb surgery, having previously experienced side effects after general anesthesia. Although a general anesthetic was advised, the patient was declined and spinal was agreed. She ended up paraplegic and in a wheelchair from generalized arachnoiditis. Now, I've unfairly done that, haven't I? Because I could easily put up the Bromley case of who ended up dying as a result of general anesthetic from failed intubation. But I want to make my case. My interpretation of NAT3 is somewhat different to Ollie's. For spinal anesthesia for intraoperative use, not across the whole gambit, including obstetrics and everything else, they quoted a rate of between 1.6 and 2.6 per 100,000, optimistic to pessimistic. That's 1 in 50,000. You compare that with GA, permanent neurological damage of approximately 1 in 5,000 at 1 year, taking into account reversibility. Now, I have to put that up because it's in the Royal College patient information sheet, and I wrote it. It's 10 times greater than the risk from a spinal anesthetic. So you might say, okay, I haven't got a case. But again, do you really believe that the incidence of permanent peripheral nerve damage, because most of the GAs are peripheral nerve damage, not central, is 10 times higher between a GA and a spinal and an ASA1 day case patient? Hands up, please. Do you really believe that? Have any of you, and no one's going to take you to court or anything, have any of you been associated with permanent nerve damage in an ASA1 patient having a general anesthetic? Any of you? 1, 2, 3. Okay. 3, I estimated earlier, with 200 people in the audience, this is a combined general anesthetic caseload of over 1 million patients. So that's 2 in a million, that's 1 in 500,000, okay? Total anecdote, but there you are. Same thing. How many of you have ever seen or associated with central nerve damage, central cord or cauda-equina nerve damage in a patient having a general anesthetic in an ASA1 patient day case? None, as expected. Because it doesn't make sense, does it? Here you are, spinal anesthetic, you're sticking a sharp needle through the dura with nerves very close to you into the cauda equina where there's less than a millimeter away, and you're putting a toxic substance in there, and possibly bacteria as well. As opposed to shoving in 20 mils of propofol. It just doesn't make sense. So is the incidence of central and nerve damage different? Well, yes, I think it is, but there's no evidence for it. And is peripheral nerve damage as devastating as central nerve? Those are the questions we need to ask. Well, if you're a violinist and you have an ulnar, because a lot of the peripheral nerve damage is ulnar nerve in GA, if you're a violinist, it's pretty important that, they're probably pretty devastated to have an permanent ulnar nerve injury, but they'd be just as devastated, in fact, perhaps not more so if you're a violinist, to be in a wheelchair. Cardiac arrest. Ollie hinted at this earlier, and I'm going to rush through it because I'm running out of time. But the incidence of cardiac arrest in general anesthesia is about 3 in 10,000, 1 in 3,000 patients. But in the Braz study of 54,000 anesthetics, there were no ASA1 patients. We're talking about ASA1 patients here, okay? In the Chopra study in 1990, 6% were ASA1, giving a rate of 0.18 in 10,000. Spinals. Roy in 97, rather worryingly, presented 6.4 in 10,000 patients. By 2002, the French had got better at doing spinal anesthesia, and it had got to a mere 2.7. And NAP3 only recorded 0.11 cardiac arrests in 10,000. But NAP3 themselves admit that it is considerably underreported because the NAP3 study was not designed to detect things like cardiac arrest. It was concentrating on neurological damage. Nevertheless, you might say, well, 0.11 to 0.18 is about the same. And don't forget, these are mostly high-risk patients. 14 ASA1 patients with meticulous care in the closed claim analysis by Kaplan. Worrying. And Pollard in 2001 wrote a review, and he estimated, rather surprisingly, that the incidence of cardiac arrest in fit young adults could be as high as 1 in 1,000 with a spinal anesthetic. I think that's a bit of an exaggeration. But when he reviewed the literature, look at this. These are the cardiac arrests or severe bradycardias. I've highlighted all the ones where the ASA class was 1 or the age was less than 50. Now, there is what Pollard describes is a vagal overtone in anxious, fit young adults with strong myocardiums, akin to the sort of thing you get that Nigel talked about with interscalene block in the upright position. Akin to, but not the Bezold-Jarisch reflex. As Ollie said, if you're inattentive, this can lead to cardiac arrest and death. However, if you are an attentive anaesthetist, it shouldn't. It will respond to simple measures. But it occurs more frequently, I suggest, than it does with a general anesthetic. And then finally, having got rid of all the negatives about spinal anesthesia, are there any real clinical advantages to spinal anesthesia in ASA1 patients? Well, this is a very important paper that came out this year in BJA by Syed, which we should, as regional anaesthetists, all hail and glorify, because this is a comparison from the American College of Surgeons National Quality Improvement Database, over 240,000 general anesthetics compared to 68 regional anesthetics, which concluded both neuraxial and peripheral nerve block. Very important paper because it showed that with regional anesthesia, any one complication was significantly reduced. An intraoperative complication was significantly reduced. DVT was significantly reduced, and respiratory complications were significantly reduced. So if this is reflected in the day case spinal type patient, day case knee arthroscopy ASA1 patient, then actually maybe there is a good reason to do spinal anesthesia. But the trouble is it isn't. He sub-analyzed it for ASA status. And these results were not significant. The results are only significant in higher-risk patients, as you perhaps might expect. So I conclude that as a potential ASA1 patient myself, I would not have a spinal for knee arthroscopy because 3 needles versus 1, low risk of TNS, but it has to be stated, a low risk of post-dural puncture headache and blood patch, but it has to be stated, significant risk of failure, pain during surgery, or GA conversion, increased risk of serious neurological, i.e. central neurological damage versus a general anesthetic, increased risk of cardiac arrest versus GA, perhaps, but a bit worrying, no reduction in significant morbidity, and the risks exceed overall the less significant benefits. So therefore, most properly informed ASA1 patients aren't going to either, are they? And if they were properly informed and want one, I'm very happy to give it. If they want to watch their surgery, that's fine. I'm very happy to do it. Financial considerations, I thought Ollie would bring up and hasn't, are of no relevance to patients. They're not relevant to patient choice. They might be relevant to medical managers, but we have to abide by our GMC Good Medical Practice Code. Are patients giving full informed consent if spinal anesthesia is the default technique in your unit? Reflect, please. But the overall thing I note is that we've been introducing these new agents, which are great agents, but there are no studies comparing it to general anesthesia. So off we go, giving day case spinal anesthetics without doing proper randomized controlled studies of the benefits. And it's about time the manufacturers did something about that and did a proper study with proper controls, with proper multimodal analgesia and proper anti-anesthesia, so we can actually see if there really is any benefit, because the evidence out there is not there. I rest my case.